Welcome to the Medical Report. Our guest today is Dr. Robert Huxster. Dr. Huxster is an orthopedic surgeon, a member of the Chester County Orthopedic Group, and he has a specialty of hand surgery. So welcome, Dr. Huxster, to our TV session on medical affairs. We'd like to know a little bit about your background as a hand surgeon. Tell me what was involved in this training.
Sure. Like other orthopedists, I did a medical school residency and in orthopedics for 5 years, and then a hand surgery fellowship. In my case, I did that in Philadelphia at Jefferson, the Hand Center in Philadelphia. And I've been practicing with a mixed practice, but including a large percentage of hand surgery ever since.
So there's a fellowship in this particular field, which makes the individuals who learn this expertise in what they're doing. So what we'd like to talk about are various issues of hand surgery. There's lots of surgery and problems that are other than traumatic or injuries that people would suffer. So let's start with the topic of a carpal tunnel syndrome. Carpal tunnel syndrome. Could you define that for us and so forth?
Sure. Carpal tunnel syndrome refers to a situation where people begin to experience discomfort in their hand. Typically, it is numbness and tingling. It involves primarily the fingers on the thumb side of your hand, your central fingers, not so much the pinky finger. It usually is sort of an insidious process where you begin to notice it occasionally awakening you at night or occasionally during the day, and often progresses over time so that the episodes become more intense, are associated with pain, sometimes pain running up the arm, and more frequent. And it can progress to the point where you have constant diminished quality of sensation or permanent numbness in your fingertips.
Is there any loss of power in the hand, the ability to grasp things and so forth?
There is, but that's usually subtle. Most of the power comes from muscles farther up in your hand, in your arm, and even the muscles in your hand are primarily provided for by a nerve other than the median nerve that is involved in carpal tunnel. So most people don't notice too much loss of power, but you can. There is some muscle in your thumb that in some people, when it is affected, will notice difficulty with pinch tasks, opening jars. More often people notice that they have trouble with tasks because they're not feeling the object properly. So buttons and items like that, zippers, become difficult.
Mm-hmm. Are there any diagnostic tests that you use to determine that it's actually carpal tunnel?
There's a series of tests, primarily exam. There's also an electrical test. The diagnosis is primarily made by physical exam and history. We confirm this with an electrical test called an EMG nerve conduction study. We also use that test to help differentiate other electrical problems in the arm that can look similar to carpal tunnel. For example, a pinched nerve in your neck can produce a similar pattern of numbness. So we want to differentiate those things so we know which one we're treating.
So the EMG is an electromyogram. It's measuring the nerve potentials, right? By sticking little needles into the hand?
There are two parts to it. There's an electromyogram part, and there's a nerve conduction study.
Okay.
The nerve conduction study involves electrodes placed on the skin that will produce an electric shock, and you can measure how quickly that is propagated down the nerve. So it's not a fun test. You feel that as electric shock. And the second part is the EMG part, or a myelogram part. It involves skinny little needles that are actually electrodes placed into muscles, and usually that's done in a series of muscles all the way down into including the thumb. And again, it's not a lot of fun. It takes to do the study in both hands probably takes close to an hour. And obviously there's a bit of an art to it.
So given a high degree of suspicion, you still run some kind of confirmatory test before you do anything, I suspect. Is that correct?
Typically we'll get the test, and again, we'll often get it primarily to discover if there's a second problem that would look similar and might be confusing.
Okay. Is there any known cause for carpal tunnel syndrome?
We think that it's primarily a predisposition. to develop the syndrome. But once you're prone to it, and many of us are, it's certainly affected by activity. So there's a combination of things that seem to play a role. Some people are just likely to get it, or more likely to get it, and then what you do with your hands, your arms, will certainly contribute. So aging plays a role as well. So it's those three things. Everyone talks about repetitive motion, things like keyboarding, and we certainly do see an association there, but some people can keyboard 8 hours a day all their lives and not have a problem. So it's a combination of predisposition, something that happens as you mature, and then use will play a role as well.
Are there any medical disorders that it's commonly seen with this?
There are certainly several things that can predispose you. The typical one would be hypothyroidism. Diabetes can make you more likely to have it. So there are a variety of medical issues that will make you more likely to experience carpal tunnel syndrome.
Okay. Well, let's talk a little bit about the treatment of this particular disorder. Can you tell us what you do to correct it?
Well, there's medical treatment or non-operative treatment, and that can be as simple as not doing something, avoiding things that irritate it or bother it. Wearing a splint at night can be quite helpful. Many people experience symptoms at night. There's the possibility of medication playing some role. No one's proven it effectively, but any vitamin B deficiency, B6 or B12, certainly can make you more prone to it, so taking those may help. And then finally there's surgical management, and many times that ends up being the right answer. As a matter of fact, there was a study done quite recently that showed that the most cost-effective way of dealing with significant carpal tunnel syndrome was to go ahead and have the surgery, get it done with.
Okay. Could you tell us what's involved in the surgery part of this?
The goal of the surgery, I made a little sketch on my way over here sort of hurriedly. It's not immediately clear what I'm drawing here, but what I've tried to depict is the space we call the carpal tunnel. So this would be as if I was looking at my hand like this, sliced like so, through the carpal tunnel. And what we're seeing here would be the bones. This would be the tunnel, and across the top is a ligament. So it's a passageway made of bones on three sides and a ligament across the top. Inside that passageway are multiple tendons, the ones that bend your fingers, and then the nerve, which is the yellow spot there. As the tendons are enlarging with this process, taking up more space as you age, and then perhaps with swelling with use, there's not enough room for the nerve, and that's what produces these symptoms. So the surgery is aimed at cutting this ligament. That's the important part of the surgery. So we want to cut this ligament, thereby making that passageway bigger, makes more room for the nerve, and the nerve, which is really a kind of a passive victim in all of this, is relieved from the pressure on it and can behave normally again. So the common or the typical way of accomplishing that is to make an incision in this part of your hand. It's usually about that long. You work your way down through the various layers until you've released the nerve by cutting that ligament. There are variations on the theme that involve shifting the incision or smaller incisions, but that's the essence of it.
Okay. And the recovery period is fairly brief, I understand.
It's really not a bad surgery for most people, whichever technique is used. For most people, the surgery is relatively comfortable. I'd say half the people that have the surgery tell me that I took one of the pain pills because I thought I should. And you can use your fingers right away. Most of us do tie your wrist up with a splint for a few days after the surgery, so there are a few limitations. Stitches are out by 2 weeks, 10 days to 2 weeks. So most people can do things like dress themselves, use the hand to eat immediately, things like driving a car after a day or two, but heavy gripping, grasping, hand tools, gardening, that's going to be more like several weeks.
Very good. Well, I think that's a pretty good evaluation of a disorder that's fairly common. And another one that's very common, if you could discuss a bit with us, is Dupuytren's contracture, and tell us what that is.
Dupuytren's contracture is quite interesting. It's something I've gotten quite interested in myself because I have it. It is the transition of a layer in your palm called the palmar fascia into a tissue that's more like scar tissue. The palmar fascia is important because it keeps your skin from staying put, or keeps your skin from sliding around. It keeps your skin staying put in your palm, unlike, say, the skin in your forearm, which slides all over. This skin here is anchored by that fascia. With Dupuytren's disease or Dupuytren's contracture, the fascia changes and it becomes more like scar tissue, and you will develop bands or pits or nodules. If the bands cross a joint, superficial or closer to the skin than the tendon or the joint, but if they cross that joint, they'll begin to inhibit your motion. So the band will restrict your ability to straighten your fingers out. The disease, which is a hereditary trait or tendency for the most part, will tend to progress. So over time, you start off with a band that you may notice, and you may live with that for 10 years, and then you'll realize it's starting to inhibit motion. It's a gradual process. At that stage, when it starts to inhibit motion, we start thinking about doing something about it to restore motion.
So what is the technique that is used to correct that?
Well, the traditional approach has been to make skin flaps, large flaps of skin, and elevate them up so you can get to those bands and remove the bands, and that's still an effective technique. And many times is the only practical technique, particularly when the process has evolved to the point where the finger is markedly impaired or markedly crooked. But at a less severe stage, there are less invasive techniques, one of which I went to Paris to learn 2 years ago. This technique is called needle aponeurotomy, and it involves using, under local anesthesia, just the needle itself that you would administer the local anesthetic with to break these bands up. And it's done as a series of steps. Once you've succeeded in breaking the band, you can restore the ability to extend the finger back out again. And it's sort of a different way of thinking about the disease process. With the surgery, it was almost like you were trying to cure it, which you really can't do because it's a trait and a tendency, and it forms again and recurs. So it's more of a maintenance approach where you use the simple technique like needle aponeurotomy, or you've seen advertised these injection of collagenase. I've seen that advertised in the papers a lot recently, as another technique of trying to do the same thing. Break the band up and restore the ability to extend, but do it with something that's simple and doesn't set you back, doesn't impair your function significantly. And if you need to repeat that again after 2 or 3 years, you can. It's easy.
Well, it sounds very similar to minimally invasive surgery of other parts, in a sense.
It's really not. It's not surgery in the traditional sense because we're really not making incisions, but it accomplishes the same end, and you're really using the tip of that fine needle as your scalpel.
Mm-hmm. How many, I guess, little injections do you have to do to?
It'll depend. It'll depend.
Yeah.
It is usually multiple. If you're doing a single finger, it may be that there'll be 6 or 8 little spots that you work. What we do first is use a tiny little needle to numb up the spot where we're going to do the work at each site. We mark them out or map out a plan for the procedure. Inject each of these spots with a little tiny needle. Once that spot's numb, you can use the larger needle. Most of the sensory fibers, the nerve fibers, are on the deep side of the skin. So these bands, which are below that, don't have much sensation. So once you've numbed the skin, you can actually work on the band without really causing much discomfort. And usually right then and there, as you're working, you're gradually popping the band in several places and end up with the finger back out straight. And the patient can walk away saying, "That's nice."
Well, that sounds like an innovation. I haven't seen that done personally to anyone, but that certainly sounds excellent. So we really appreciate this discussion about carpal tunnel and Dupuytren's contracture, 2 of the more common things that people will get as they get older. Please stay with us because we're going to have another session with some more problems that people can develop in their hands. So we'll be right back in a few minutes.
You don't have to
Welcome back to the medical report. If this is your first exposure to this topic, this is Dr. Robert Huxster, who is a hand surgeon from the Chester County Orthopedic Group, discussing different disorders of the hand other than the trauma that we experience and what we do about them. So again, thank you for joining us for this discussion. One of the topics we're going to discuss is something called a trigger finger. So could you tell us what a trigger finger is?
Sure. The trigger finger is something that we experience as we get older. You don't see it very much in 20-year-olds, but later in years, 40s, 50s, and on up, it's a situation where a finger will catch. It often is a nighttime phenomenon, but it can occur any time during the day, where the finger will snap or lock and get stuck and then be hard to straighten back out again. And so it can, and the triggering phenomena refers to going through that tight spot and then getting stuck, or going the other way, finally releases and comes back out straight again. It's a problem of the tendon that bends the fingers. It can occur in any finger. People sometimes think of it as trigger thumb because they're used to hearing of it in the thumb, but any finger can be involved. It is a little more common in certain situations. Diabetes, again, is one of those things that can predispose you to trigger finger. The problem is that the tendon that bends the finger, and there are actually two in your fingers, is binding or catching back at the entrance to the sheath or passageway that holds the tendon down to bone. So the tendon that bends your finger is attached to muscle up in your forearm and passes through your wrist, and just about here enters a passageway called the sheath. And that is where the triggering occurs, and it's also where the discomfort occurs. Some people, the trigger finger will be relatively painless, and some people, the trigger finger problem will be quite uncomfortable or painful. Some people really have only the pain and don't really have the catching or locking, so it can be a little bit of a spectrum. But typically the tenderness will be right there in the palm of whichever finger is involved, and it can often be multiple fingers involved.
We have a lot of golfers in this community here, and tennis players. Does this sort of thing contribute to trigger fingers? Is it traumatic or what? Probably
not. This is one of those things that we don't really know why people get it particularly. And it's not so much associated with activity as it is just an aging process, I think.
So it won't interfere with their putting or anything like that, I suppose.
Well, having it might interfere with putting. Okay. It certainly can interfere with your grip.
Okay. And so what do you do to correct this?
Well, some people will simply wear a splint in order to avoid having the finger pass through the catching spot. That's not a very practical solution, but in a painful situation it might be helpful. Again, you can use anti-inflammatory medications, sometimes can be helpful. In the office, when I see people with trigger finger, most of the time what I end up offering them in their first visit is an injection. It's a steroid delivered by injection into the tendon sheath, usually with some local anesthetic at the same time, can resolve this about 75% of the time. And when I say that, it really is referring to an injection or two or even three. So 3/4 of the time we can make the problem go away with an injection or two. The injection does hurt a little bit, but it works pretty quickly. It takes the pain away within a day typically. The triggering or locking usually takes a few days, a week to resolve. That means that there are 25% of people where an injection isn't going to help. So for that we do a surgery. The good news is that this is a very simple surgery. I usually do it under just local anesthesia. It's about a 1/2-inch incision over the tender spot. We numb up the area that we need to work, go down to that tendon sheath, and what we're going to do is simply open the sheath or split the sheath where the tendon is binding. The tendon has a bump or a nodule on it by the time it gets to the point of needing surgery that is hanging up, and by opening the sheath we can allow that nodule to pass through the tight spot without it being a problem. And that solves it. So I always think of this disease as a totally curable process. One way or another, I can make this problem go away.
Does it happen in more than one finger?
Frequently,
Yeah.
I'd say more often than not, more than one finger is involved.
Okay. Now there's another disorder that called tendonitis, and we know most people are familiar with tendonitis in their shoulders and so forth. Could you tell us a little bit about the tendonitis in the hands?
Really, the example of trigger finger is a tendonitis, and so it's a inflammation of a tendon system. There are other tendinitises that are fairly common. In particular, a very common one is tendonitis along the border of the wrist here, and that will be often feel like there's discomfort or pain in the entire area, and sometimes it's hard for people to localize at first what they're experiencing, but they usually will begin to realize that it's somehow tied in with the thumb, and that's because the tendons involved are tendons that help you lift your thumb up. That's got its own fancy name. It's called de Quervain's disease or de Quervain's tendonitis, and that has the same treatment. It's really the same problem as the trigger finger, but it's not in a flexor tendon. It can be treated with an injection, or if that fails to solve the problem, it can be treated with the same simple surgery.
Mm-hmm. Are these hand tendonitis problems as painful as the shoulder ones are?
Sometimes they are. I certainly have people that feel they're totally incapacitated on occasion by the tendonitis problem.
Mm-hmm. And sometimes the non-steroidals help that?
Yes, as we talked about with trigger finger, the tendonitis at the wrist can be treated with splinting. It can be treated with anti-inflammatory medication. It can be treated with icing. There could be a role for formal therapy for this tendonitis, the de Quervain's tendonitis. More commonly than trigger finger, we might try therapy. Modalities like ultrasound, for example, might help.
Mm-hmm. Okay, very good. Now, one of the other things that we get in our hands, and people aren't aware of it, but we get significant arthritis in our hands at times. So can you tell us a little bit about arthritis, where it most commonly occurs, and are there different types and so forth?
Certainly.
Yeah.
Just like other parts of the body, arthritis in the hand can occur from the more common, what we used to think of as wear and tear arthritis, known as osteoarthritis or degenerative joint disease. We now know that that is also largely hereditary, so there's a strong family tendency to have that problem. There are other kinds of arthritis that can affect the hand too, rheumatoid arthritis and other similar related kinds of inflammatory arthritises. The treatment for these is just like in other parts of the body, primarily medical, at least to start off with. So medications to help control symptoms, and in the case of rheumatoid arthritis, the rheumatologist can sometimes slow down the process with some of the newer medications. With the more common osteoarthritis, we don't really have medications or ways to stop that disease. We're really treating symptoms. So Advil or prescription anti-inflammatories typically. Sometimes resting splints can be helpful. With the osteoarthritis, the joints involved typically will be the end joints of the fingers or the knuckles, and not so much the joints at the base of the fingers. Also early and often involved is a joint at the base of the thumb, and that's probably the one I see people coming and complaining about most commonly. Is, again, they're not exactly sure what's hurting them, but they're aware that something is bothering them when they go to open a jar or grip or pinch. They're having pain that stops their being able to do those things somewhere down here. And typically it's arthritis at the base of the thumb or between the base of the thumb and one of the small bones in your wrist called the carpal bones. That arthritis, we can treat those same ways that we talked about. But frequently that one also can be treated or ends up being treated surgically because it can be debilitating enough that it makes sense to do that. That's not so easy as some of these other surgeries we've been talking about. That's a little bit more like a total joint replacement kind of surgery in a hip or a knee, in the sense that we're making major changes. There are, in fact, total joint options, but in the hand they don't hold up very well. They're not very reliable. And most hand surgeons use a rather old technique to deal with arthritis in this joint of creating a interposition arthroplasty, of creating a spacer made out of your own soft tissues. So the surgery consists of removing some bone so that there is no joint anymore, just like with a total hip or a total knee, and then creating a spacer out of soft tissues, and there are a variety of ways of doing precisely that. It requires a long period of immobilization for that to work, though, so this surgery is a little different than the ones we mentioned earlier that have a quick back to normal function time frame. This one is casting for 6 weeks and another 6 or 8 weeks of recovery involving hand therapy in order to become pain-free again. But it is effective.
I'm sure many of our viewers have seen people with this very deforming rheumatoid arthritis of the hands, and particularly these proximal muscles or joints here. Is there anything you can do for those folks?
Rheumatoid arthritis is a little different. As you mentioned, it involves frequently these knuckles, much more so than the others. And there's a tendency for the fingers to shift or aim towards the little finger side. It's referred to as ulnar drift. So the fingers tend to slide that away. It's associated with changes in the way the tendons are working, as well as destruction of the joint. So earlier in the process of rheumatoid arthritis, there can be surgeries, there could be splinting to control position at night. Resting splints can be quite helpful. Surgically, there can be correction of the soft tissue misalignment of these tendons and realigning of the fingers. And finally, there can be a joint replacement type of surgery. And in people who have rheumatoid arthritis who develop these severe deformities, because their ability to use their hands tends to be pretty limited in the first place, these artificial joint ideas or joint replacement modalities can have a role there, because they can hold up in someone who's going to have limited gripping and pinch force involved in the first place. So there is a role for some sort of an artificial joint in people with rheumatoid arthritis.
Well, this has been a terrific discussion, I think, for our viewers. I'm sure if we could get the phones ringing, we'd get a lot of questions. Is there anything that I haven't asked you today that you would like to share with our viewers that they might be of interest in?
I don't have anything else planned to bring to your attention. I think we've covered the basis for these more common complaints. Of course, there's lots and lots of more esoteric and puzzling problems that we run across that make life interesting every time I go to the office.
Well, I'm sure you're inundated with work, because orthopedic surgery is such a terrific field, and there's so many patients that have arthritis. We certainly appreciate your coming and visiting with us today, and I'm sure our viewers have enjoyed it very much. So thank you very much for joining us today. We hope you learned a lot more about the hand, and a lot more than just injury. So thank you for watching, and stay tuned to Keep Informed.